whenever somebody is asking you about any surgical procedure, then surgical procedure you have to tell, first thing you have to tell that which anesthesia, under which anesthesia it will be. Okay? Of course, what is the indication for that particular surgery in that particular patient? Because for any surgery there may be more than a dozen indications, but what is that particular indication in that particular patient? Then is the anesthesia, preoperative workup is done. Then on the operation table, what will be the position of the patient? Because during surgery, the position of the patient will be different. Post-operatively, the position will be different. For example, if you have to go for example, nephrectomy, so patient will be different position. Okay, patient has to undergo, for example, some surgery on lumbar spine, position will be different. So in tonsillectomy, the question may be what is the position operative and what is the position post-operative. So someday when we will talk about the post-operative care of a tonsillectomized patient, then we will talk about. So on the operation table, first thing is that it is done under general anesthesia. So similarly, whenever someone will ask you about the complications of surgery, any operation, you will always start with the complication of anesthesia. Because anesthesia, we know it is of different types. It is general anesthesia, it is spinal anesthesia, it is local anesthesia, it is nerve block. So every anesthesia has got its own complication, and that is a part of surgery. Okay. So tonsillectomy is done under general anesthesia. Then on the operation table, the position of the patient is what we call as rose position. Rose position is that patient should be lying spine with a sandbag or pillow under the shoulders. So when there is sandbag is under the shoulders, neck is automatically extended. Okay. So same position is being used for any surgical procedure over the neck. For example, thyroid surgeries, for example, tracheostomy. So same is for oropharyngeal surgery, especially this tonsillectomy. Then surgeon is on the head side of the patient. On the head side, the surgeon is sitting there. After intubation, when anesthetist handovers the patient to you, then we have to open the mouth of the patient. So for opening the mouth of the patient, we use this instrument which is called as Boyle-Davis mouth gag. This is just like a D. So Boyle-Davis mouth gag, you will hold it in left hand, and then you can see these are the tongue plates or tongue blades, and you can see these are of different sizes. Because in a small child, the oropharynx will be small, so you will use smaller size, then larger. In adults, you will use that. Okay. Then it has got a slots here. So these slots, and this is the lock. You will unlock this. You will put it there and slide it. It goes inside. So for example, a patient is lying here. Okay, head side. I am on the head side of the patient. So when I will introduce this will towards the tongue of the patient, and these things, this will be over the upper incisors. So upper incisors will be entangled here in this slot. It should be covered with rubber so that the teeth are not being injured. And then you release it, and then you gradually open it. And you release it, you see it is locked now from here because the slots are there. So it is being locked. So how much you want, you can open it. Okay? Because patient is under muscle relaxants. So the complication which has occurred, that so many inexperienced, they just open it with force, and at the end of the operation, patient could not close the mouth. Why? Temporomandibular joint has been dislocated. So every movement has to be very sophisticated. How much force is needed for all these instruments? It will look easy when you are looking from a distance, but then until and unless you feel these things with your hands, then you know how much force is required and everything. Okay, so very gently you have to open whatever you want. Once it is there, then either your assistant should be holding it like that to keep it. So for 30 minutes, 45 minutes, 1 hour, one person will be occupied. So instead of that, we use this thing which is called as Grafen's tripod. Tripod because it has got 3 structures, 3 constituents. These are suspension rods. And this is the base. So what happens? You have introduced it, you have opened it, then you will just apply these, and here in these holes it will be fixed like that, and this is there in the mouth. So automatically it is entangled there, it is suspended there. So you don't need any assistant and your both hands are free now. Okay, so this is suspension rods. If these two are there, if all three, then it is Draffin's tripod. DRAFFIN', Draffin's tripod. So this is Boyle-Davis mouth. Now, for example, if there is some lesion on the undersurface of the tongue or floor of the mouth, then you cannot use this, isn't it? Then you can use a different kind of mouth gag, which is called as Doyne's mouth gag. D-O-Y-N-E, Doyne's mouth gag. So this prong is towards the upper jaw and this is towards the lower jaw, and you can open the mouth like this. So that, and you can apply two on either side as well. So what will happen now? Tongue, floor of the mouth is available for any kind of manipulation. Okay, so this is Doyne's mouth gag. This is again a mouth gag, but this is it is not used in tonsillectomy. In tonsillectomy we use. Okay, so in picture if they show you only this one, this is Boyle-Davis mouth gag. If this is also there like this, then you will label it as Boyle-Davis mouth gag with tongue plate. With tongue plate. Okay. So this is Doyne's mouth gag. Then there is another instrument, if you see, this is sharp one. This is basically mastoid retractor. Why retractor? When you have gone for post-auricular incision for mastoid exploration, skin, soft tissue, periosteum is being cut. So that should be, separated so that directly you are over the bone. So keep it retracted, those soft tissues. You can use this retractor so that remains open. You don't need to have assistants to pull that. So this is mastoid retractor. So this is different. You see, it is sharp, entangled. This sharp one you cannot use in the mouth, okay? And this is blunt. So you have to keep in mind these differentiating features. Okay. These are the curved dissecting scissors. These are blunt, so you have to dissect the tissues sharp, and then at the same time you have to cut it. This is called as dissecting scissors. Go into that planes, you will land in trouble always. So here the dissecting plane is subcapsular. So you have to hold it. So just to hold it, that we use this instrument, which is called as, this is also the same, this is what we call as tonsil holding forceps. Tonsil holding forceps. To be precise, its name is Dennis Brown tonsil holding forceps. Dennis Brown tonsil holding forceps. So we will just hold the tonsils with this one. Another instrument with which this is confused, that is this instrument, which is called as Lux forceps, and you see apostrophe S, Lux forceps. So these two instruments, how you have to differentiate. This is the instrument which is being used in nasal surgeries to remove the septal cartilage during septoplasty and SMR, to take the punch biopsy, or to remove, for example, polymydal masses, anything, to use this Lux forceps. How to differentiate? As I told you, the name for this forceps is just tonsil holding. So just we have to hold it. So we don't need much pressure here because we don't want to crush the tissue. We don't have to punch the tissue. Okay. So if you closely look, when I close it, the upper limb and lower limb, there is a gap between two limbs. So when there is gap between two limbs, the force here is less. Because if that goes inside, then you compare it. Now, just have a look at that. Upper limb, it is, going inside the slot. When it is going inside the slot, the jaw have got maximum force, cutting forces. Cutting force is there. Even you can take a bone piece along with that one. Okay. Secondly, if you closely observe, its upper jaw is shorter than the lower jaw. So when upper jaw is shorter than the lower jaw, it means the force here is not that much. When you see here, upper jaw exactly comes over the lower jaw. So that maximum force is here. So this is the difference. So this is Lux forceps and this is tonsil holding forceps. Once you have held this tonsil holding forceps, then you give an incision over the mucosa only, because mucosa is the same which is reflecting over whole of the oropharynx. So to just cut the mucosa, and then tonsillectomy, which we do, there are different methods of tonsillectomy. Usually in routine, what we are using, or internationally even is using most commonly, is what we call as, what is the method of tonsillectomy? How do we remove the tonsils? What are different methods of tonsillectomy? So we use dissection method. So we have to dissect the tonsils from its bed in the subcapsular plane. For that we use an instrument, this one, which is called as tonsillar dissector. Okay, if you see, it is flat from side to side and it is lined rough so that it is not slipping from our hands. You have to hold it, this instrument, like a pen. Most of the instruments in the ENT, you have to hold it like a pen. Okay, so you will hold it like this, and from this side, if you closely observe, there are serrated edges, so that the fibrous bands which are making the tonsil adherent to the underlying tonsillar bed, you will separate those fibrous bands with this one. You are holding it and pulling it medially. Dissection is always traction and counter traction. So you are holding the tonsil medially and you are dissecting it with this forcing laterally, so that it is being dissected out. So when you reach up to the lower pole, there you can use this instrument, which is called as tonsillectomy sphere. It is called as Eve's tonsillectomy sphere. EVE apostrophe S. Eve's tonsillectomy sphere. That, because just imagine the patient is lying. I am on the head side of the patient. So the upper pole of the tonsils is lower down, isn't it? So from upper pole we will start and we will come towards the lower pole. Lower pole is where it is continuous with the lingual tonsils on the base of the tongue. That is the limit of. In surgery, the most important is always what not to cut. What not to cut is more important. We must know our limitations. That up to what extent we can go. Because once we have gone beyond the limits, we cannot come back. If we are short of limit, we still can proceed. So general principle is, most important is what not to cut. So that is the limit of the lower pole, and in the lower pole, there are minor vessels, there is no major vessel. So what we want is basically that we want it to crush that tissues, so that hemostasis is automatically there, and at the same time tonsil is being removed. So what will happen that we will, you can see this is a wire, very thin wire is there. We will introduce this tonsil holding forceps. That tonsil which has been dissected, now only it is attached with the lower pole. Rest of we have dissected from the bed. So we will deliver that tonsil through this forceps and we will go towards the lower pole, and then gradually we will close it. When we will close it, you see this wire has disappeared inside. So when wire is disappeared, that soft tissues it has crushed, not cut. When it has crushed, the minor blood vessels, for hemostasis, it is important that the surface should be rough, and then platelets, aggregation and clotting and all that mechanism, so that is being crushed, their edges are being crushed, so hemostasis is secured at the same time, and the tonsil is being removed. Okay. After that, now is the tonsillar bed, anterior pillar and posterior pillar, tonsil has been removed. Now we have to look for that whether there is some bleeding point or not. For that, we will use the other side of this tonsillar dissector. You see, this is not serrated, but it is a rounded one. So this is what we call as pillar retractor, because pillars, as I told you, is like this. So for example, if here is some bleeding going on, from here it will not be visible. But when I will retract this pillar, then I can see the bleeding point. Okay. So for bleeding again, there are the same principles. First is the pressure. Minor bleeding will be stopped by simply the pressure. If still some ooze is there, we can use the electric cautery. But if still some major vessel is there, or if it is not being controlled by, then we have to go for ligation. So different types of sutures we can use. Then this is another instrument. This is also pillar retractor from this side. For example, this is bleeding is here on the upper side. Okay, so we can or just adjacent to the edge of the anterior pillar. Okay, so then we can just hold from this side, this anterior pillar. So again, this is a kind of pillar retractor, depending upon the scenario and the situation and the site of the bleeding. You can use this one. So bleeding, if we have to go far, then we can use these instruments. These are called as artery forceps. Again, these are general artery forceps. These are different sizes. These are large artery forceps. This is straight, so this is called as straight artery forceps. This forceps, which is called as curved artery forceps, these are used in the abdomen as well, in the neck as well, anywhere, these just to catch the bleeding points. So either straight or this one, we can use the forceps. Then there is a specific artery forceps which is being used in tonsillectomy. That is this one. Now you see the difference between this forceps and this curved artery forceps is that here is angle 90 and here is even more than 90. So when the angle is 90 or more than 90, then this is forceps which is called as Negus artery forceps. Negus apostrophe S. Negus artery forceps. Okay. So what happens is basically, for example, there is a bleeding point, and as you know, the tonsillar fossa, or there may be one main bleeding point, and adjacent areas may also be having some bleeding points, multiple bleeding points in an adjacent area. So instead of dealing with them individually, collectively we can deal with that. How? We will just hold it like this, that, and then we will use this Negus artery forceps as a replacement, like this. Then we will remove this. Now more tissue is there, okay, and over that we can apply a silk knot. Okay, so when silk knot will be applied there, what will happen later on with ischemic necrosis, this portion will be shed off and that stitch will also come out. No need to remove that. Okay, or you can use on needle also. There are different methods of, but usually we use this one. Okay, so this is Negus artery forceps. Then is this is again a general instrument. This is called as towel clip, because to start with we wrap the patient with sterilized sheets. To keep the sheets in their place, we can fix them with this. This is called as towel clip. There are different shapes of this. One is this one. If others come, then I will show you. Now, usually what happens is that we have to go for adenoidectomy as well. Okay, so in adenoidectomy, the position of the patient will be just supine. There will be no sandbag under the shoulders. Okay, the patient should be supine. Then again, after applying the mouth gag, we have to go behind the soft palate into the nasopharynx. For example, the patient is lying down, so I will go into the nasopharynx. Then I will feel the posterior border of the nasal septum. From there, I can Now, tonsillectomy is done by dissection method. Adenoids are being curated. So adenoidectomy is done by curettage. So that's why this is called as adenoid curate. Okay. Now you see, these two are adenoid curates, but there is a difference between. Here you can see that there is an extra piece is there, and there are sharp spikes are there, so that whatever the adenoid tissue will be removed, it will be entangled here. Will not slip downwards towards the larynx. So this is called as, so it guards against the slipping of the adenoid which is being curated into the lower airway. So this is called as adenoid curate with guard. And if simply this one is, this is simply the adenoid curate. So this is adenoid curate, this is adenoid curate with guard. These are also of different shapes. This is the suction tip. This is pharyngeal sucker end. Its name is Yankees pharyngeal sucker because it is used in the pharynx. So this will be at the end of this suction tube. So we will use this suction tip, which is called as pharyngeal suction tip or pharyngeal sucker end or Yankees suction tip, whatever you want, you can call it. This like this. Okay, so this is the tulicums nasal speculum under on the operation table. Patient is under anesthesia, so even we can touch the mucosa. Okay, so that's why blades are so long. In OPD we cannot use so much long. Now for nasal surgeries, the patient will be supine with the head side up 45-degree angle almost. So So that will be the position of the patient for nasal surgery, and surgeon will be on the right hand side of the patient. So now the position is different. Okay. Then there are another speculum. Okay. So this speculum, again different sizes of the plates accordingly you can use. So this is called as Killian's nasal speculum. Now you see the difference between these two is that it has got a screw here, okay, and it does not have any screw, okay. The reason being, when you are operating a form, for example, you have introduced it, posteriorly you have to go far, so long bladed you are using, you will open it like this in your left hand, so that right hand should be free for any manipulations, okay. So once it is open, for example like this, so if surgery is going for say 1 hour, 2 hours, you cannot hold it like this continuously. At the end of the surgery, your hand will be, like this. So what happens? You will open it whatever you want, then you just, close this screw. So what will happen? It will remain there. Now you can even hold it like this. Okay? So this is what it is called as a self-retaining nasal speculum. Now it is on itself retaining whatever we have opened it. While this will not be self-retaining. So this will be Killian's nasal speculum, simply. This will be self-retaining Killian's nasal speculum. So when this screw will be there, then it is self-retaining Killian's nasal speculum. So that is the difference between the two. Okay. Now, then this is what it is called as knife handle. Knife handle. It is general. Anyone can use. Here the blade will be, surgical blade will be attached. These surgical blades, they have got different numbers. So there is number 11 blade, number 15 blade, number 21, 22. That is very large. In abdominal surgery, 22 or 21 are used. Usually we use 15 number blade, that is a bit curved one. But all those blades, they can fit in this slot. So this is a general knife handle which can be used in any surgery. Okay. So in septal surgeries, we know that we have to give the incision in the mucopericardium, then we have to raise the mucopericardial flap. So for that, this instrument is used, which is called as Freer's elevator. F-R-E-E-R. That's just like Freer's incision. So this is Freer's elevator. Mucopericardial elevator and mucoperiosteal elevator. And just don't confuse it with that tonsillar dissector. Okay, I showed you in the tonsillar dissector. In tonsillar dissector, its central part is flat from side to side, while this is rounded one. One thing. Secondly, its edges, rounded one, there is no serrated edges like this here. Okay, so this is tonsillar dissector with pillar retractor, while this is on both sides, it is rounded one. Even in the middle it is rounded one. Again it is rough here, so that we should hold it like a pen and it should not slip from our hands. If it is smooth, then it may slip from your hands. So that's why they have made it rough. So this is flat in the middle from side to side with serrated edges on one side. So this is tonsillar dissector with pillar retractor, and this is Freer's elevator. With that raise the mucopericardial flaps, and then that cartilage you can remove it with that lux forceps. And then that bony spur you can remove it with the hammer and boot. Now for suction, we will use this suction tip. You see now its shape. Its shape is just like nasal floor. So this is nasal suction tips. Again they are of different sizes, but the shape will remain the same. Again this is a towel clip. Now this forceps, this is called as Tilly's forceps. In the nose it is very commonly used, T-I-L-L-E-Y''S. If you don't remember the name Tilly's, you simply can say it is nasal dressing forceps. It is used for anterior nasal packing. It is used to remove that anterior nasal packing. So during surgery it can be used for control of epistaxis. If you have to go for anterior nasal packing, you can use this one. So this is Tilly's forceps. Then if you see this forceps and this forceps, okay, so this is Tilly's forceps, whole limbs are moving, here only upper jaw is moving, okay, so this is called as Tilly-Henkel's forceps. Okay, it is used to remove polyps, for example, or some tissue for biopsy like that, so it is used there. But this one is used for nasal dressing forceps. Okay. Then again, this is a common, generally is used. If you see there are small tooth here, so this is called as tooth forceps, tooth tissue forceps, just to hold the tissues. This is. Now, if spur is there, we have to remove it. Bony spur is there, so at its root we have to break it, that bone, with hammer and gouge. Okay, and this is what we call as chisel. Either we can use the chisel or we can use the gouge. Gouge is the one, on one side is straight, the other side is beveled type, and these are of different sizes as well. So this is gouge, this is hammer, and this one like this, so this is the chisel. So hammer, gouge, or hammer and chisel we can use, and at the root we can just break its attachment, and then we can remove that bony chunk, bony spur from the nasal cavity. Now this is another forceps, only upper jaw is moving. Okay, and you see it's a small size. So this is used in the ear. Okay, this is called as crocodile forceps. Just like crocodile, this upper jaw only moves, alligator. So this is called as crocodile forceps. This is used in. And these are the ear speculums. I don't know why he has put it here. Now see, this size is larger than the previous suction tip I showed you, that nasal suction tip. It is more wider. Okay. Sometimes more blood is coming, or secretions are thick. This one may be blocked, so you can use a larger size, but shape remains the same. Two important forceps. Okay, so you see it is a bit curved. This one is, both are straight. Okay, so this straight one is Walsham's forceps. This is Walsham's forceps. This curved one is, it is called as Ashes forceps. Okay? So fracture nasal bone is there. We have to manipulate the nasal bones during fracture. We will use this Walsham's forceps. On one side you can see this rubber guard is there, because when we have to move the nasal bones, manipulate the nasal bones, this prong will be there in the nasal cavity. This prong will be here outside. So this guard is so that when we put the pressure, outer skin should not be damaged. Okay? So we use it, and then we can manipulate the nasal bones. When we go on the other side, again this prong will be there in the nasal cavity, this guarded side will be outside, and we can manipulate the nasal bones. Okay? So this is Walsham's forceps. And in septum, which is usually fractured, it may be Jarjari fracture or Chevalier fracture. So we have to manipulate that. So if it has gone down, we have to elevate it. It has gone backwards, we have to pull forward. Here we use this, which is called as Ashes forceps. If you don't remember Ashes forceps, you can say that septal alligator forceps. But how do you, there is no guard here, because one prong will be in one nasal cavity, other prong will be in other nasal cavity, and then septum is there in between. If you have to elevate it, you can elevate it. If it has gone backwards, you can pull it forward. Okay, so you can manipulate. So if he asks you that which forceps is used for manipulation of nasal bones, Walsham's forceps, and Ashes forceps is used for the manipulation of the nasal septum. Okay. This instrument, if you can see, this is called as RASP. This is RASP, RASP. In this reduction rhinoplasty, then there is a hump, bony hump. So you can reduce this hump with this RASP. Okay, so this is called as RASP. See how small is this Pirian's nasal spine. This is not self-retaining. Okay. So this is the Eustachian catheter. I have shown you already. This is smaller size. Okay. This is foreign body hook from the ear. We have to remove this. So this is called as foreign body filling. Rhinoplasty. You have to lift the skin and soft tissue. This can be single hook. If one is there, single hook. This is double. So this is double hook. Retractor.